right, thank you for staying with us. It's Good Morning Nigeria. Now we're moving on to the conversation segment. And today our topic is on management of Nigeria's healthcare system. Ekene Ndulue has a background there for us.
Statistics from the United Nations reveal that globally, average life expectancy stands at 73 years, while that of Nigeria is 55, making Nigeria one of 4 countries with the lowest life expectancies in the world after the Central African Republic, Lesotho, and Chad. At the root of early deaths in the country is a healthcare system riddled with challenges due to acute underfunding and poor working conditions. With a population of about 200 million people, Nigeria has a population ratio of 1 doctor to 2,753 persons, a far cry from the World Health Organization's recommendation of 1 doctor to 600 persons. This number keeps getting worse by the day as more doctors are leaving the country in their droves in search of better working conditions. A recent study in a journal, BMC Public Health, showed that since the launch of the National Health Insurance Scheme, NHIS, in 2005, less than 5% of Nigerians have taken up health insurance, while the rest of the population continue to finance their healthcare needs through out-of-pocket expenditure. To tackle these challenges, the federal government in December 2020 unveiled the Nigeria's health sector roadmap with a 9-point medium-term plan to ramp up the push towards universal health coverage. The agenda includes implementation of mandatory universal health insurance, operationalization of the Basic Healthcare Provision Fund, and reduction of gaps in all health-related SDGs by at least 60%. How far has the federal government gone in the implementation of this agenda? How can Nigeria's health system be better managed for improved health delivery? Guests on Good Morning Nigeria will be speaking to the issues in a moment.
Thank you very much, Ekene Ndulue, for that elaborate background. With us in the studios, I would like to welcome Dr. Osagie Ihianire, is the Honorable Minister of Health. Honorable Minister, pleasure to have you again on Good Morning Nigeria.
Thank you, and good morning.
Okay. Well, let's begin by taking off from where our correspondent left off in the background. We have a number of schemes. We have a number of policies. We have an elaborate law, that's the National Health Act, National Health Insurance Scheme, and pronouncements and claims as to what we will do about our healthcare system. But there's no question that Nigeria's healthcare system is challenged, and some would say severely so. What are the lingering issues?
Well, there are many lingering issues, to use your own terminology. First is the question of personnel, and then the question of setting of priorities. But there's been a lot of work going on in resetting priorities, putting emphasis where the weaknesses are. The weakness mostly at the moment is at the primary healthcare level, and the question of health financing and setting the right priorities. Where do we begin? Where do we begin to put in more resources? It will not help to throw money into it unless it's targeted and planned, and that expected outcomes are well determined ahead.
Councillor, are you listening? All right, let me go back. Sometime in the course of our research, we came across a certain quote which says that describes America's health system as neither healthy, caring, nor a system. And I began to wonder if that is so with the American health system. How do we describe or evaluate our own health system? And I think you're in the right position to do that for us.
Well, yes, there is no perfect health system in the world. If you want to compare various health systems in various countries, you'll find different outcomes. But there are lessons to learn from everyone. There are countries that invest very heavily in healthcare. if you are looking at it as per capita or as total investment. But the outcomes are not that fantastic. And the others that invest very little, but they get good outcomes. So it depends on where you put your money, how you put your money in, and how you also get the people to work with you, how you do community mobilization, and also arrange the demand and the supply. So Nigeria's health system is a work in progress. And we have been doing a lot of background work now to carry out certain repairs, and very soon you'll be hearing of a primary healthcare summit, which is upcoming in October. We have new initiatives at the health insurance scheme area, and also the president recently set up a health reform committee to look into the entire structure and see how to get the best gains out of the investment that go in. Investment comes in first from government, from private sector, and from foreign partners. We're trying to galvanize foreign partners to put the money in the right place, and also to work with the private sector to do the same. With the government side, it's a little tricky because the health system is said to be on what is called the residual list, where state governments play a role, local governments are supposed to play a role, but the federal government generally provides guidance. And as you put the guidance in place, you expect that the other partners go along with you. But some seem to go in a different direction. If you want to emphasize primary health care, for example, others are replicating tertiary health structures in areas where the need is not there for mighty tertiary hospitals. So there's a bit of a discordance in the relationship between federal, state, and local government with regard to healthcare. We're trying to get all of this in line. Just a few days ago, we signed off letters to governors advising for a better alignment to start with primary healthcare. Every health system has a foundation, and that foundation is at the level of care.
If you were to assign ratios, percentage, because maybe to someone who is just coming in to say, okay, how would you rate in terms of percentage the health of our healthcare system in investments in the different areas that you would invest in human resources, in financing, and of course in the availability of tools? What would be your rating?
Well, the rating is difficult, but right now I will put emphasis on human resources at the lowest level. We just heard of the statistics, the life expectancy in Nigeria, maternal mortality, infant mortality, under 5 mortality, TB deaths, HIV deaths. All of these go on at the level of the primary health care, at the rural levels, in slums, and in those areas where health care has been neglected for years. Those are the people you can say are the forgotten people, the forgotten Nigerians. And that's where you get all the statistics from. And that's where the healthcare should begin. The rest of it has to rely or lie on the foundation. Foundation being, again, primary healthcare, and secondary healthcare, tertiary healthcare, and then specialty healthcare. All of these should be joined by two things. One is an emergency medical service that makes it possible for Nigerians to get help when they need it and where they need it. And then the second being the question of arranging the health financing in such a way that it answers the questions which we are posing, and not just money flowing in and you don't know what outcomes you are benefiting from that.
Okay, Honorable Minister, let's just step back a bit and perhaps take a socio-cultural view of our healthcare system and see where we are transitioning from. At a time when there was heavy reliance on tribal medicine to now orthodox medicine, you would say probably in the last 100 years or so, there's been the infusion of orthodox medicine. Now, related to this transition phase, it's also a matter of attitude and orientation. Do we get a sense that healthcare isn't just a social service to be provided by government, but also a paid service for which you and I have to be responsible, at least to some extent.
Yes, you are correct. Both of these approaches are right. In the first place, what you call orthodox medicine or modern medicine has its roots in traditional medicines of other countries in the past, which the tools of science and the search for knowledge have now brought in an organization and a body of knowledge that we now call medical studies. If you look at the founders of medicine, Hippocrates, Galen, and so on, you find that most of their prescriptions were like traditional medicines of today. So that there is a connect in there, and there are people who still believe in what they call traditional medicine, but again, some call it herbal medicine. That differentiates it from the magic type of medicine that people sometimes also propagate. But on the whole, there is definitely the need for a transition, where that is the reason why we today insist on community engagement, on social and behavior change communication, and on getting the communities to own the facilities they have. The primary health care centers we are propagating right now are going to be in the communities, and we have ward development committees that are supposed to be part of the governance so that there's a sense of ownership. We're also propagating the fact that the health workers at that level, the community health extension workers, for example, should be recruited directly from the communities and trained and returned to their communities where they are well known, where there's going to be more acceptability, because acceptability is part of what you are talking about now. Rather than pick a number of people from the city, train them, and then take them to rural areas where they don't have a sense of belonging, where the people do not have a sense of recognition of these health workers. So we need to have a new strategy. We need to rethink the way we're looking at the health service delivery here, both the infrastructure and then the human resource for health.
I also want to extrapolate this to aspects of healthcare financing. Because when you look at the traditional medical system that people still patronize, I'm just wondering, you know, when a person approaches a healer, a traditional healer, for instance, you pay for it. You pay, whether it's by way of divination. If they ask him to go and bring one small goat, the person will go and bring one small goat. If they say go and bring one small fowl, chicken, you will go and bring it. It is not the herbalist that will give you, that will provide those things for you. If it is for purposes of divination, you are required to put something down before the diviner proceeds. You see some of these things on African magic channels and so on and so forth.
Casey, can we just put him on hold and bring in the other two guests?
No, let him take this question. You know, so if, therefore, you pay for this, why is the orientation that you go to a government hospital and you say, I went there, they say there is nothing for me? Or you are willing to spend from your pocket for that? That's why I asked the question whether there is a perception of orthodox medicine as a social service to be rendered by government compulsorily, or a paid service as well, as part.
Yes, you're correct again, because it is both. You will know, recall that virtually every politician who is campaigning for office now will promise you free everything, free education, free health, free housing. There's nothing free at all. But once you begin to give that promise and give the impression that things can come to you free of charge, then of course you create expectations that yes, everything will come free. And when you really don't get it, there's a sense of disappointment in the government. So again, it's a matter of responsibility that politicians do not continue preaching free things which they can't deliver, or things that they know that are not even calculated. If you want to give free health, how much will it cost? Do you have the money? And if you don't have the money, you can't say that you are going to deliver it. So that's one aspect. The other aspect is that people really do pay for health because we calculate there's up to 70% out-of-pocket expenditure in the health scene today. People go to the pharmacy or medicine store and actually pay for medicine. So on the one hand, they pay. On the other hand, they expect government to give to them for free. From the private sector, they will pay. They pay at private hospitals. They know they will pay. They know they will pay when they go to the medicine store. But once they go into government hospitals, they think, well, the politicians promised me to be free. So why are they asking me for anything? So there is a need to re-message the information that the public gets.
All right, thank you, Honorable Minister. We have two guests joining us via Zoom. One from Lagos is Dr. Gafar Laodi, expert in finance and health. Dr. Gafar, thank you very much for joining us.
Thank you very much for having me.
All right, and the second guest is joining us from Maryland, United States, is Benjamin Uzoma Nwosu. He's an adjunct professor of nursing at Washington Adventist University, Maryland, USA. Mr. Nwosu, thank you very much for joining us.
Thank you for having me.
Okay, let me start with you, Mr. Gafar. We're already speaking to the issue of financing health, but general question, how would you, from your perspective, evaluate a healthy healthcare system? What are the adjectives that qualify a healthy healthcare system?
Okay, thank you very much. I think to start with, let's try to understand the objective articulated by the country for the health sector as contained in the Nigerian Health Policy document of 2016. The central objective, which is not different from what you see elsewhere, is to achieve universal health coverage, which means everybody must have access to health care of good quality to be effective without experiencing financial hardship in the process. I think that's a very huge concept and it's a global one that Nigeria has subscribed to. And I think that's the standard for appraising health system performance anywhere in the world. So what does that mean? And where is Nigeria with regards to this concept of health, universal health coverage?
Okay, I'd also like to ask if we have him on, Benjamin Nwosu, if you can hear us, can you share with us what qualifies the healthcare system where you are as a healthy one that makes everyone want to, come over to the US to either to practice or to access medical care? Okay, we'll try and get our connections right. I think our engineers are working on that, Kingsley.
Okay, back again to the Honorable Minister of Health. We know that progressively there's been the private sector intervention in our healthcare system. And there are a number of issues relating to that. But it's like what we also find with education. On account of the challenges in the public sector education system, you've had a climb in private sector participation. So perhaps Nigeria could work out its own model. But you trained in Germany. What was the healthcare model like in Germany? Something, of course, Germany is an OECD country and one top range in terms of medical services. What was it like? Who owns the healthcare system? Who funds the healthcare system? And how does it run?
Well, there's a lot to learn from developed countries, and they all have various systems. To go back to the question you asked just now about universal health coverage, what you need first is availability. That is to say, you must have the structures available. In Germany, that is, and other European countries, that's a given, in the sense that in nearly every community, there will be a doctor in practice somewhere. But we cannot have that kind of structure here because survivability economically is not assured, but you can have medicine stores in many places, even in tiniest villages, but the quality is questionable. The second thing is affordability. Can you afford it? Well, most persons there have health insurance. In fact, the concept of health insurance started in Germany under Bismarck, in the sense that they made the employer pay for the people they employ. But then we don't have so many people here in employment. More people are more on their own. So you have to vary what applies in your country if you're applying it to another country. And then, of course, the quality of healthcare. And which is why, again, to answer your question, people want to go to the United States or to the UK because they feel the quality is better. We here should also be striving to improve the quality in order to create more confidence in our health system. Then there's this question of accessibility. How far is the hospital? Some people cannot get there because it's too far. And finally, the fact that if you have a problem in your house in the middle of the night, what do? Do you pray and wait till next morning? Well, in those countries, all you do is dial a number and help comes to you in your house. And nobody's going to ask you to pay at the point of service. So even if a lady is having a delivery and has complications, either obstructed labor or bleeding heavy, well, if you want to wait till next morning, you are almost certainly going to lose that person. But if you have help to call upon that will come to you, you can save a life. The same goes for a child. And the same goes even for adults. If you have an asthmatic attack or a heart attack or something, or a stroke. So the question of an emergency medical service that does not impose an unnecessary burden on the user is needed right here, and that will reduce the indices that we are so worried about. So it's a mixture of various approaches that one has to use in a country like Nigeria, judging by our population, and then the spread of facilities. And at the base of it all is the primary health care, which can be run by a nurse, can be run on contract, can be run in very many different ways, because it answers the question of availability and then accessibility. And then the insurance that you pay, little bit every month that you pay, answers the question of affordability, because your insurance will pay for you. So nobody's going to be asking you to pay before you get your treatment.
Okay, let's return to the U.S. Adjunct Professor of Nursing, Benjamin Uzoma, of course, is joining us via Zoom from Maryland. Uzoma, I asked earlier on, and the Honorable Minister has given us some hints to my question, but you are an adjunct professor of nursing, and you also have experiences in both long and short-term managerial, experience in management in the clinical nursing area. What would you tell us about what qualifies a well-managed healthcare system such that many Nigerians, and indeed many people from all over the world, come to the US to access healthcare or even to practice? And I know you're practicing there.
Thank you so much for having me, and good morning to the Honorable Minister. What qualifies a good healthcare system in the United States here is a system where everybody, no matter who you are, no matter your level of income in the society, receive adequate health care. I'm not just receiving health care, but receiving quality care. And for you to be able to receive adequate health care means that the system or the government attaches a high importance to you as an individual that deserves adequate health care. Like they say, that health is wealth, and that a viable citizenry is a healthy citizenry. Therefore, the system is such that the government procures policies that tries as much as possible to treat every citizen equal, irrespective of your level in the society. Therefore, in terms of managing the healthcare system here, the government has come up with so many policies. Just like Nigeria and every other country, yes, United States still struggles with trying to provide universal health care because they believe that everybody deserves health care. But despite the effort by successive governments, it has not been very, very successful or adequate. Therefore, a lot of policies have, for example, you can imagine a country as huge as United States devoting about 17% of their national GDP on healthcare alone. And despite this high cost, the country continues to strive as much as possible to see how much they can bend the curve of this high cost of healthcare without impacting quality care. So that is the system we have here. United States actually believes so much that every individual must receive health care that is affordable. And to make it affordable means that there should be policies in place to make it a possibility. So that is the system we have here.
Okay, thank you, Benjamin Uzoma Nwosu, for the points that you have raised, but I still would like to stay with you. Let's not, we'll get into some controversies around the quality of healthcare in the US and affordability. I mean, a leftist writer like Noam Chomsky will tell you with data that amongst the advanced countries of the world, the US healthcare system is the most expensive, and it has the least universal coverage for its population, even in per capita terms. But there are some things that I would like you to speak to based on your experience in the US. That's to say, perhaps just general administration or facilities, X, Y, Z. When you look back to Nigeria, what do you find as the most worrisome challenges about our healthcare system?
You mean about your healthcare system in Nigeria?
Yes, our healthcare system. I imagine you are a Nigerian as well. Yeah.
Well, I read a lot of news regarding Nigerian healthcare system and what is going on in Nigeria. I think the problem with your healthcare system, for example, I'm looking at what you spend or what the country spends on the healthcare system. About 3.7% of your national GDP on your healthcare system. Now compare that to 17% here in America. So that goes to tell you where the country attaches most emphasis on. For example, if Nigeria believes that health care is a necessity, if Nigeria believes that health care is necessary for every citizen, they must devote enough resources for health care. You can imagine the gap between 17% and 3%. Yes, 17% in US does not mean that United States is comfortable with the 17%. Yet, they have, like I said, they strive annually or with successive government to ensure that they reduce this level of percentage, but at the same time, not impacting quality, like I said before. But is that obtainable in your country, in my country, which is Nigeria? Yeah, I'm a Nigerian, okay? So is the same thing obtainable in Nigeria? I don't think so. I think whatever you attach interest in is what you devote your time and your resources on. Now, I do not think that Nigeria attaches so much interest on health. Otherwise, I see no reason why we should be having doctors and nurses leaving the country in droves. Why? After all the resources spent on them to be trained in Nigeria, only to be used outside the country. Now, the system there is not. It is not. I mean, it's not such that will really treat healthcare as an important aspect of the system or of the survival of the citizenry. So here we have, somebody mentioned, I think the Honorable Minister mentioned about 911. I mean, can you imagine a country here in the United States whereby if there is an incident, you do not need to wait till the next day. All you need to do at the comfort of your room, you dial 911 and somebody comes in to pick you up to the hospital. Nobody asks you how much you have or if you can afford it or not. But guess what? They are treated. And then after treatment, then comes the billing. And in most instances, the patient may not have the money to pay. Guess what? The government picks it up. Is that obtainable in your system? I don't think so. So that is the disparity between the two systems.
I'm still tempted to stay with you via Zoom. Just explain this for us, because the Honorable Minister made a point. He says that part of the focus in reforming our healthcare system is targeted spending. Now, you've given us absolute numbers. Say 17% of the US GDP is spent on health. Here, we spend about 3% of our GDP. I don't know about those numbers. That's for us here in Nigeria, 3%, whether these expenditures out of the public purse or whether it's private spend. Now, when you say 17% of GDP is spent on healthcare in the US, what are the areas of expenditure that then help to sustain the healthcare system?
Well, the areas of expenditure with respect to GDP, first, you talk about the technologies. United States devotes so much resources on technologies because I think the medical system here is such that everything is handled by technology. Therefore, a lot of resources are devoted to technologies. That's number one. And number two, there are so many there are different types of paying systems whereby physicians and other healthcare personnel they tend to create charges for outrageous input now for outrageous medical care provided. So, and that is why, despite the outrageous charges, of course, the government still pays for those charges, but they come up with policies to see how much they can curtail those outrageous charges. And that is where this is one of the reasons why they promulgated the Medicare, Medicaid, because they realized that the medical providers were charging outrageously. Then the government decided to come up with Medicare and Medicare policies, in which the government will have some element of control over some of these charges by medical providers.
All right, thank you, Adjunct Professor Benjamin Uzoma. Let's put you on hold now and bring in Gafar Laode, who's an expert in financing health. He's also joining us via Zoom. Dr. Laode, you started giving us an explanation about why we have not achieved adequate coverage in the area of universal health care. The Honorable Minister has said that investment is targeted. Of course, financing would be one of those. So please, could you go ahead to give us your own perspectives on what you think is wrong or we have not done in the area of financing health?
Okay, thank you very much. Once again, thanks for having me, and good morning, Honorable Minister Sam. So like I started earlier on, the policy focus of any country in the world now is universal health coverage. But in terms of where we are in Nigeria, I think, of course, we still have a longer way to go in terms of number of people accessing care, which is very, very suboptimal. And central to that is the issue of suboptimal financing. I agree with the Honorable Minister. We have started doing something, but the problem is still very huge in terms of figures of what we are spending so far. So in terms of our spending per GDP, I agree with Dr. Benjamin. We are spending around 3.5 percentage of GDP on health, but that's not even the biggest problem, because in the journey of universal health coverage, what is more important, it is the public spending. What the 3.5% is what everybody is spending as a proportion, as a percentage of GDP. When it comes to what government is spending as a percentage of GDP, is less than 1%. And then available benchmark says that for countries that have made significant progress in the journey of universal health coverage, they spend at least, government, I'm talking about government now, government spend at least 5% of GDP on health. Public spending, why is public spending very, very important? Public spending is very important because in any situation, no matter how low, for example, the health insurance premium is, there are some people that are actually not able to afford it. And those people that are not able to afford it are the ones that constitute more into the burden of disease, constitute more into the poor health indices that you see. So there must be a system where we take care, somebody has to take up the bill. And again, given the credit to the government and the Honorable Minister, there are a lot of policy instruments that are already in place. Chief among them is the Basic Care Provision Fund, which is meant for buying basic minimum package of care, where the law says to all Nigeria, but as the Honorable Minister says, the money will not go around. So there's sort of a targeting poorest of the poor to ensure that they are taken care of with the Basic Care Provision Fund, which has started. But it can only go far because don't let us forget that this Basic Care Provision Fund is coming from federal government. We need to ensure that the state government are doing their own aspect as well. And that is why in each of the states, they have a state health insurance scheme. And in their state health insurance scheme, they have what they call equity fund, which is 1% of their consolidated revenue, which is meant for buying, taking care of the poor and the vulnerable. Only very few states have released this money. So part of the advocacy is not only about looking at the federal government, to look at the state government as well. Then secondly, it's not only about making the money available, the efficiency of spending. How efficient are we? How do we ensure that even the little resources that we are spending money on, we are spending it well? If you look at a typical state government budget in Nigeria, their health spending, no matter how small it is, they spend almost 70%, or average of 70% on the workforce, which is very important, which is very necessary. But how are we efficient with this? Even the one that we are spending on the workforce, are the workers there? Are they productive enough? Are they competent enough? Are they very, very responsive? So we need strong governance and management system to ensure two things. One, that we spend more money on health, and at the same time, we are getting best result for the money. So in terms of prioritization, one of the senior colleagues in this field once said, the starting point in the journey of universal health coverage is not technical. It is the political and the ethical consensus that health is human right. That is the starting point. If you look at countries that have made serious progress, I'm talking about low and middle income countries now that have made significant progress in the journey of universal health coverage. There are some commonalities among them. And one of the commonalities is that there is strong political ownership for the universal health coverage agenda. You can see things starting from either Mr. Prime Minister or Mr. President, telling the whole country that I want to go the way of a universal health coverage. And when Mr. President or Prime Minister says that, everybody has to key in, and so it's gained serious political momentum. So that is very, very key for us to happen now. Then two, many countries are using health insurance, which Nigeria is using as well. So the issue of subsidization, what we are doing in this country is not likely to take us to universal health coverage, apart from the great work around basic care provision fund. If you see, most of the health insurance that we have is the emphasis on contribution. State health insurance will say, come and pay premium. The truth of the matter is that the statistics have shown that if you ask people to come and pay contribution, even when they pay this year, they're not likely to pay next year. And even the cost of pursuing paying for contribution might be very, very difficult. You can argue that government does not have all the money. But at the same time, we have to look at, okay, let government contribute the maximum they're able to contribute. Then at the same time, let's look.
All right.
I don't know. Dr. Gafar Alawode, well, we're just wondering whether you are back. I would have. All right, Dr. Gafar, please continue from where we lost you a moment ago.
Okay, can you hear me now?
Absolutely.
Okay, thank you very much. So I said, in addition to what we have done already, the truth of the matter is that we have to give credit to the Honorable Minister during his period. The implementation of basic care provision has gained momentum. And even there is an aspect which we were not actually paying too much attention to in the past, the emergency care. I think he brought that into the limelight to ensure that emergency care is well taken care of and other aspects as well. So what I'm saying is that, of course, basic care provision fund is not going to be enough. We have to ensure that the state government are doing their own bit. One of these days, I'll be more than happy if you can bring the chair of the Nigerian Governors Forum here as well to discuss what the governors are doing with regards to health in their respective state, so that we'll be able to mobilize. Like I said earlier on, there's this equity fund, 1% of consolidated revenue. It is enacted by, there's a legal provision for it in each of, in almost all the states. The states are not actually paying attention to it, they're not releasing the money. But in addition to releasing the money, we have to pay attention to what is the money buying and how efficient are we? Because when you put Nigerian health system side by side with other countries, evidence has shown that many low and low and middle income countries are much more efficient than us. In terms of average productivity of health workers is higher in many other countries than ours in terms of absenteeism, and in terms of to some extent ghost workers and all those stuff. So we have to pay attention to efficiency. Then again, emerging evidence are showing us that even when you have basic care provision fund, when you have health insurance scheme, when you release the equity fund, it's not enough. You have to do the community part of it. There are instances where people are registered on basic care provision fund, on equity fund, and they don't even come to the health facility to assess the care. So, and then we have seen evidence where if there's a strong community intervention to increase awareness, to improve health seeking behavior, things will improve. So we have to look at both the financing and the health system as a whole, the community aspect of it, and pay attention to issue of human resource for health, and look at alternative way of financing in addition to what government is doing. Let me give you an example why it is very, very important for us to look for alternative way for financing. So the benchmark for government financing towards achieving universal coverage, like I said earlier on, is 5%. But is that 5% government spending on as a percentage of GDP, government spending on health, is it actually feasible in Nigeria? It's very, very difficult, because the evidence shows that Nigeria is only collecting 7% of GDP as revenue. So if government is collecting 7% of GDP as a revenue, how is it possible for government to spend 5% of that of GDP on revenue? So we have to look at a bigger picture in terms of ability of the country to collect revenue and spend revenue on social services, including health. Other African countries, they are revenue average of 15%. So why is Nigeria only collecting 7% of GDP as revenue? Of course, that's not the question for the Honorable Minister of Health. It's the question for the Honorable Minister of Finance to answer. So there are bigger issues that we have to look at. But in the interim, because that will not change overnight, we have to look at what are the additional way of mobilizing resources. The private sector potential is there. People now talk about blended financing. People talk about private equity as a way of mobilizing additional resources. But at the same time, more importantly, even the little one that we are spending, how can we be more efficient on it? I would like to stop here for now.
Well, Dr. Gafar, well, you're stopping, but we're also retaining you briefly to respond to one of the issues that you raised. You talked about political will being usually a potent factor in the success of universal health coverage in medium and low income countries relative to Nigeria. You said, for instance, a prime minister or a president of a country would say, look, this is what I would like to achieve. He becomes a champion for wider universal health coverage, and then he proceeds with it. I wouldn't know whether you have any example to cite, because that could also assist us, I believe, in evaluating our system and knowing what is right. In terms of political systems, in those jurisdictions that you mentioned, do you have the sometimes antagonistic relationships that we have in Nigeria? I mean, the president could say something and a state government will say, look, that's not a priority of our party in our state. Oh, this is a federal government agenda. Oh, this is not what we are doing in our state. Or you are doing this at the federal level. Well, there's something else that we are supposed to be doing. Do you find that, let me put it this way, is it, say, in authoritarian or near autocratic regimes where you can have that, say, look, there's this political will and you can make it percolate throughout the particular jurisdiction?
Okay, thank you very much. This is an interesting question in terms of the obstacles to policy reform in the journey towards universal health coverage. So I agree with you. Of course, most of the countries that have made progress, it's not that they did not face obstacles. It's only normal for one party or the other or individual to antagonize for whatever reason. But what has helped in some other country, even when the prime minister or minister say, president say, I want to go this way, is not to see policy reform as a mere or technical process, but to also see it as a political process as well. And let me give you an example of Turkey. Turkey is one of the celebrated countries in terms of universal health coverage among the low and middle income countries. Of course, and then the starting point is, apart from the political classes who want to go this direction, the first thing they did is to do the political economy analysis of the policy reform. In other words, to understand the influence and interest of actors and institutions. Who is likely to say no? Who is likely to say yes to this reform? And that's the starting point of the reform. That engagement, those that are likely to say yes, to engage them, and those that are likely to say no, to try as much as possible to engage them, and try as much as possible to design the policy process in such a way that we affect, because even those that say no, at times they have genuine concern. So they have genuine concern about how things should be done. Taking that into consideration, those that are likely to support it, bring them together as much as possible. I think that that always helps. Don't let us belabor the point that somebody will oppose any policy process. It's only normal for people to oppose a policy process. That's the normal thing in the public policy space. But what is very, very important, like even Benjamin will allude to that in the United States, the process of reform, they did serious political economy analysis in terms of who is likely to support, who is likely not to support. I think we need such in Nigeria as well as we do policy reform. Some of us have conducted studies around the political economy of even the Basic Care Provision Fund to understand what went wrong, what we can do differently, and others. So that is very, very important. Like in terms of champions, like countries, even in our own Africa, Paul Kagame was is likely a very strong champion of universal coverage. But the caveat is this: we have to be mindful of that fact. Rwanda is not Nigeria. Rwanda is a unitary state. We're a federal state, so we have to take that into consideration as well. In Ghana, the process started during election. When I said it's a political process, I don't mean only the minister or the presidency, but it started during the election when the new party wants to come in. And part of what the new party sold to the electorate is that we are going to improve your access to health. They used to have what they call cash and carry in Ghana, where it's only out of pocket payment, which does not take them anywhere. So as a result of that political process, when the new party came into power, they started the process. The same thing applies in India. It was started as a political process. And in terms of what we need to do, elections coming in 2023, I think we have to raise the bar, accountability bar, in terms of asking the political class, in terms of, okay, we have seen some reform that are helping. What do we want to do? Political party ABC, what do you want to do in terms of reform? And we should not accept, we make healthcare free for all and everything. We should be asking the question, why? What is the policy thrust? What is the policy reform that we would like to do? I don't know if I've answered some of the questions that you've raised.
Right, Kingsley will be back. I'm sure you must have.
No, he certainly has. He's answered those questions and further elaborated on it. But he also drew attention to the risk of absolute comparisons. I mean, sometimes some Nigerians are quick to point out, to say, see what's happening in Rwanda. And he very rightly observed that Rwanda is a unitary state, and Paul Kagame has been in office for about 20-something years. Can you try that in some other locations?
All right, let me bring in Honorable Minister here. I know there are a lot more you want to talk about. Issues have been raised in terms of budgeting percentage and all that. But please, let's look at what goes on outside of financing healthcare. People say, probably the indices you talked about, maybe infant mortality and all that a lot more Nigerians die more from the bureaucracies and inefficiencies that go on in the hospitals than even the sickness themselves. For instance, you go to the hospital, public hospital, you want to obtain a card, it takes you the whole day, you spend the whole time, hours, trying to obtain a simple card. You go from lab test, they give you maybe 1 year date, and the person probably would have passed on, even before the due date. So these kind of inefficiencies and gaps at the primary level, how do we address them? How do we governize management at that level to make it more efficient and effective?
Well, thank you. That is why I am particularly happy that the President set up this Health Reform Committee, because it will address everything from the structures to governance to service delivery and of course the efficiency that goes along with it, which is clearly everybody knows about and nobody wants. And it has to do with the system that exists. Tying the hospital system, health delivery very strictly to civil service ways is difficult, and it's very difficult. So there has to be a bit of freedom, a bit of relaxation of put everything at grade level. Everybody is thinking about moving from one grade level to the other, irrespective of your performance. It depends on how long you have been in one place, and nobody cares how many patients you saw or how many operations you did or how you did your work. Those things really have to begin to change, and I believe that the health reform will look into that aspect of governance and poor service. Again, it has been said that in some countries there is one organ in charge of healthcare, the federal, or it is well divided among states. States know that this is their responsibility in their various domains. But here in Nigeria, it is split among many players.
But it's not working.
Exactly, and that's why we're looking for ways to change that, because a lot of burden. If anything goes wrong in the health system, the finger is pointing at the federal, is pointing at the president. In reality, a lot of things are going right in the federal, but they may not be going very well at subnational levels. But everything is blamed on the federal. But the health system in Nigeria is actually There are many players in there, the state government, the partners. What we have been trying to do is galvanize all actors and have a better coordination. I said earlier that we are working with the health partners who bring in money, but they do what they like. I want to work here, I want to work in this state, I want to do malaria here, I want to do TB. So there's a lot of duplication, and a lot of it is wasted effort. And sometimes even loans that we took to address certain health issues are not really following the direction that government wants to go. So we are working on getting everything better organized and better utilized so that the outcomes are better. Also trying to work more with the states to spend better, more coordinated spending, and involving local governments and the private sector in particular. We are talking about the emergency medical service and ambulance system now, which will bring in the private sector. It's a co-managed initiative between private and public to bring all ambulances in the country to use for an emergency service that will be paid for. You are assured that you'll be that you are paid, so the end user does not need to pay anything at point of service. Even at the point of service delivery at the urgent care center, you are guaranteed. So someone is not brought in and has to pay for a card and doesn't have the money, so you leave it by the side. You are guaranteed that you'll be paid. So there is going to be a good response to that.
That's a 911 call for you, Honorable Minister of Health. All right, it's Good Morning Nigeria live on the network service of the Nigerian Television Authority. We'll take a short break now. When we return, we'll continue with the conversation.
Well, the housing solution we have developed is a multifaceted one. First, we have tried to lead a program to build what we think will be an acceptable and hopefully affordable housing type based on surveys we did in 2015-2016 and construction that started in 2017. And that's going on in 34 states as the National Housing Program.
This message is from the Federal Ministry of Information and Culture.
Dear compatriots, our country can be as great as we want.
Let us all commit ourselves to its greatness.
We must be willing to set aside our differences, unite and stay as one.
In our expansive landmass, human and material resources, and plurality lies our strength.
Let our challenges lead us to rediscover our common ground, and together, let's find solutions.
This will take some time, so it requires patience, tolerance, and forgiveness from every one of us.
Let all hands come on deck to protect and transform our country.
Let us unite and see each other not as adversaries, but as brothers and sisters.
Together, we can build a better Nigeria. for ourselves and for the next generations.
This message is brought to you by the National Orientation Agency, NOA, with support from Nigerian Television Authority, NTA.
After a surprise loss in the first match of the season, the citizens have hopped their campaign back on track. Will they continue in their winning form, or can they be stopped? Find out this Saturday as Manchester City welcome Southampton to the Etihad Stadium on the Premier League Live, showing on the network service of the NTA from 2:30 p.m. The Premier League Live is brought to you by Baba Ijebu and powered by Integral.
All right, welcome back to the program. Let's again get back to the Honorable Minister of Health. Honorable Minister, I'd like for you to explain more on the emergency ambulance services. You said it will be paid for. I'm sure every Nigerian will desire a situation where he or she sits in the comfort of, their homes and then dials a particular number and an ambulance officer picks the sick one and seamlessly. Is that what is likely to be the outcome of this scheme?
Well, first of all, it is not a taxi. It is not for anybody to sit in the comfort of their home and dial an ambulance to come and pick them and take them to the hospital. That is not what it is. It is an emergency medical system. You must be in the state of an emergency. So if you abuse it, or you pay, you'll be made to pay for it. If it's discovered that it's a frivolous call, you want a taxi to take you to where you should be paying, normally going by yourself. And the system is such that there is 5% of the basic healthcare provision fund that is earmarked for emergency medical services. Now, this amount is not much. So we have thought, how do we get about it? If you want to buy ambulances everywhere, you are not going to succeed, because you have to worry about managing the ambulance repairs, the paramedics, the drivers. The best thing is to use this 5% in a way that allows you to pay for services. And you pay for services both from government-owned ambulances, even company-owned ambulances, agency-owned ambulances like road safety, or privately owned, so that any service that is provided is paid for on an agreed tariff. To see a patient with paramedics and take them to an urgent care center without asking them to pay. So it's managed in a way that this fund now pays for the service that's given in these areas. You do that to save lives, because there are situations where even wealthy people at that very moment do not have a penny on them, and then they stand the risk of being ignored in a hospital if they have an urgent problem.
I'm just wondering, Honorable Minister, listening to Dr. Gafar Alawode, amongst the many points he raised has to do with the policy process. And happily, there is this committee now chaired by the Vice President on healthcare reform. Now, allied to that is what he referred to as the political economic analysis of reform. I'm wondering, rather than the brick and mortar case of, we have infrastructural deficit, we have manpower deficit, we have this, we have that. Have we tried sometimes to take a step back and undertake a rigorous political, economic, even if cultural analysis of our healthcare challenges and what can be done by way of remediation?
Yes, you are correct. And that is one of the main questions that the Health Reform Committee is going to address. Take a step back and look at the health system in its entirety and also work on it. Last week, I inaugurated a committee to do something similar with the National Health Act, to take a step back, examine all the provisions in the National Health Act, and tell us how well we are following and complying with the National Health Act. A lot of the provisions have been addressed and are being addressed. But it's a continuous process. You can't stop at a point. And you also have to be able to engage as many actors as possible. The Nigerian health system is peculiar in the sense that there are many actors in there. And part of the, again, political act you need is bringing everybody together under one umbrella, who previously have worked on their own and done what they feel like. And also, in many cases, wasted resources. doing things that didn't need to be done, or not doing things that really urgently require to be done.
Thanks, Claire. Dr. Gafar Alawode, if you're still there, Dr. Gafar, there's a point I would also like you to speak to in seeking to understand our current healthcare system and therefore point a direction for reform. And it has to do with the structural issues. The Honorable Minister himself seemed to have touched on that very briefly. That namely, look, healthcare professionals, well, in a sense that medical school is tuition free for public universities, federal public universities, we have that. When you then come out, who are your employers in the first instance? To whom are you responsible? And how do you move? How do you, sorry, that's your upward mobility. How do you graduate from one level to the other? What is your responsibility as an individual? What is the responsibility of the state to you for the healthcare professionals? Sometimes you have all these squabbles among doctors, pharmacists, nurses, and so on and so forth. So are those structural issues also an impediment to our healthcare system, and how therefore might we reform that aspect?
So, sorry, you are breaking up at the point. Can you quickly summarize the question again?
Okay, I'm saying that from your perspective, what structural issues constitute impediment to the efficiency and the management of our healthcare system? Namely, for instance, take personnel. Say you have doctors, you have pharmacists who get trained virtually for free in federal public universities, and then they come out to get employed. Who are their employers? Can a different system of employment be found for them? But at the same time, they earn well. And then how do you manage the relationship amongst the various healthcare professionals?
Okay, thank you very much. If I get you clearly, I think probably summary of it is that how do we improve the efficiency of the system, especially looking at the workforce as well. So my own understanding, management of anything in life starts with data. You have to understand what is the current situation, what are the issues, what are the challenges, how many workforce do you have, what is their distribution, what is their productivity, what is their, how responsive are they, and how how in terms of the technical know-how that they have. So the government has started something which is a step in the right direction. We just need to do more. There is this arrangement around having a workforce registry, and it's a form of human resource for health information management system, where at all levels we know how many doctors we have, how many nurses per population, and then what is their productivity and all those stuff. I think that's the starting point. And it is not enough to gather this information. We need to have an institutional arrangement for saying, for example, in terms of different parameters of workforce management, what is our target? What are we doing? What do we need to do differently? How do we tie spending? Because part of the problem that we have, and it's not only Nigeria, many developing countries, there's a disconnect between spending and results. Like, for example, if a typical state government tells you they spend 7 billion on health last year, they are not able to answer the question, how much health have they bought with that 7 billion naira? What is the productivity of the workforce? Now that we are putting system in place to manage this data, I think it is very important, not only at the national level, at the state level as well, to put that similar system in place where we are really managing, we are gathering the information and we are using the information for decision making. Let me give you an example. There's a particular state where we did the tracking of resources. Within a period of 7 years or thereabout, expenditure on personnel grew from around 1.5 billion to around 7 billion, after 7 years. And the question was that there was no significant change in the salary scale or something. And worse still, there was an embargo on recruitment during that period. We only got to know because we did the tracking of resources, and we put the resources side by side, the health outcome and the output in terms of our workforce. Interestingly, during this period that workforce expenditure grew from 1.5 billion to 7 billion, the density of workforce actually declined during that period. So the question is that there are a lot of wastages in the system. But the point is that if you are not actually tracking to look at those where the resources is going, and that is why we are doing resource tracking resources, and look at what the money is buying, it's very difficult to manage efficiently. So to me, data is very, very important, and using that data for decision making to know where we are making effort. And the question is that in terms of managing our workforce, is this everything that governments must manage directly? Can we outsource some of these management of, can we outsource some of this management to like private entity could be much more efficient in doing this? I think those are things that need to change in terms of looking at generating data, using data for decision making, and looking at other options for management, including bringing the private sector in to manage aspects of the healthcare system. Over for now.
Thank you, Dr. Alaode. Thank you. Let's quickly take a minute or two from Benjamin Nwosu. And I'd just like you to, let's learn one or two things from your system, how we can address the incessant strike actions. We rarely hear of medical practitioners going on strike, but here it's almost a given.
Sorry, can you repeat your question again? Because
what lesson can we learn from the U.S. system in terms of abating incessant strike actions by medical doctors? It's almost a given, situation here.
Okay, I'm not sure the question was clear, but I think
I can repeat my question. Yes, I said, just share with us what lessons can we learn from your system on how to stop frequent strike actions by medical practitioners in Nigeria.
Okay, thank you so much. I think I get you now. Yes, first and foremost, we have to learn and understand that I'm looking at the ratio of patient to doctors in Nigeria. I was going through some study. It's about I think 1 to almost if I'm right to 100,000 or 10,000. But now compare that now to about 295 to almost 100,000 here in US. So we have a lesser doctors to patient ratio here. That's number one. And number two, the system here tends to have a lot of incentives for medical providers here, and that is why they even go to the extent of asking medical providers from outside the country to come in with already available job for them. That's number two. Then number three, we have the American Medical Association. The American Medical Association here controls to some extent how providers are deployed from school, from their training down to the places of practice. So the American Medical Association has a strong influence in regards to how the personnel is managed. So a lot of things could be learned from this. And again, there was something Dr. Gafar said regarding a curtailing of cost. Now, one of the major problems we had here before the inception of affordable healthcare, which we call Obamacare, was that America was concentrating mostly on chronic diseases. So most of the time, people do not seek primary care. So that with every they allow themselves to have to get to the point of having chronic illnesses, which most of the time are not well managed. And when it becomes so severe, they go for emergency medical care, which ends up costing more. So, which is one of the things driving healthcare costs in America. So now, the Affordable Care Act now looked into this and said, okay, I think one of the main reasons for the promulgation of that act was to see how they can curtail these frequent emergency care visits by ensuring that we have what is called the primary care, which we call the gatekeepers. So the gatekeeper, that means making sure that every American have access to primary health care. And that, according to study, has decreased the amount of money spent on healthcare with respect to the GDP. So that's very important. And not only that, now the government decided to invest more on primary care providers. And now we have what is called the nurse practitioners, which I'm part of. Now, the government now had to open up, opportunities for advanced nurses to get into practice and then compete with these medical providers, to doctors and other
I just
medical
want
personnel.
to,
In order,
Benjamin Owonsu, please, very quickly, a word or two. When you say the government is, of course, funding primary health care, is it the federal government of the U.S. or both the federal and state and county administrations?
Say it again, sorry.
Okay, you said that there has been a push to ensure that primary health care, the so-called gatekeeping healthcare system that you have now, who is the funder? Who is driving it? Is it the federal, state, or county administrations?
Well, it's controlled by both federal and state. Controlled by both federal and state. But the most important thing is the reimbursement. So every primary care visit is reimbursed by either the state or the federal. So now there is this encouragement by the federal to ensure that every American has access to primary care, because without access,
we're getting pressed for time. I just wanted the Honorable Minister of Health to also respond to this, because there's been a push to revitalize our primary healthcare system. There was a time in this country when the primary healthcare system witnessed a sea change under Professor Olikoye Ransom-Kuti when General Babangida was military president. There has been an attempt now to restart it. A few states painted 1 or 2 buildings, and after that, we never had anything again. What can be done to ensure that primary health care is revitalized and sustained?
Well, primary health care has suffered because it is not so glamorous to pursue. So most persons running states want large, visible, glamorous, and tell you, yes, I equip with this, I bought all this equipment and so on. But in the majority of the cases, you find it difficult to run these hospitals, because hospitals of that size in the wrong place are a liability. You will not have the resources to pay for the services, to employ the workers in there, and they have not done a good service. So most areas will do with a very well designed primary health care. What we have done so far is to redesign the primary health care structure to now include staff quarters, so that personnel can stay and offer services round the clock, particularly for emergencies, midwives, children, and so on. And then the human resources that are to be improved for what they call task shifting and task sharing, to be able to do several things. And then human resource program for human resources to remain, because one of the problems we have is attrition People are employed one place with either there's a lot of absenteeism or they disappear, they come 2 times a week for work. So all those things really need to be, look at the problem and find a solution for it. So the primary healthcare system, the whole network, is the foundation that takes healthcare closest to the people. And we are trying now to draw attention to it with the summit that we are planning. There's a new design, there's a new payment structure, and above all, also the health insurance aspect, which we hope will come on stream very soon to inject more money into the system, and the aspect of community engagement, community ownership, that they know that this belongs to us. It's not government only.
Dr. Sage Hanire, Honorable Minister of Health, would like to appreciate you as always for finding time to join us on today's conversation.
My pleasure.
Thank you. Let me also appreciate Dr. Gaffar Lawode, expert in finance and health, who joined us via Zoom from Lagos, and also adjunct professor of nursing at Washington Adventist University, Maryland, USA, Benjamin Uzoma Nwosu, who joined us also via Zoom from Maryland. Thank you, both of you, gentlemen, and do have a wonderful day. All right, this is Good Morning Nigeria. Let's take a look at what is entertaining us on entertainment.